This conference is no longer being recorded.
Well, that's no good.
This conference will now be recorded.
Okay. We have a couple of guys who were on our first Speaking Freely call on Thursday night, which was a great success, and where Jackson did a wonderful job. And the next call will be on the 21st of Feb. And of course, we'll send out a notice, but I encourage you all to join. It was a really sweet call. And so we have somebody else. Excuse me for pausing, but I see we have somebody else on the line. A caller.
Hi.
Who is that?
Hi, it's Al. I just called in. I couldn't find the access code. Sorry.
Okay. All right. Okay.
I got it, Rick.
Okay. It was a lovely call, and the purpose of that call is to discuss everything other than treatment. So, because it's open to all cancers, and so we don't want to make it into another technical treatment call. And we stayed pretty well outside of treatment, other than a couple of introductions. But we have on that call Joe and Keith B, who have never been on this call before. And so I will ask them if they're comfortable to introduce themselves one by one, not at the same time, and to tell us a little bit about their background and how they're being treated, where they're being treated. If they have any issues, they should feel free to bring them up. And given the number of people, I'm going to try and keep each person to about 20 minutes max. So the quicker you are in telling us how well you're doing, the longer you'll have in talking to the guys. Okay? So Joe, would you like to take it away?
Sure.
Okay.
I'm working, I guess, audio wise, right?
Yes, you're doing great.
Okay, good. I live in Boulder, Colorado. I was 55, and in the fall of 2016, I just finished this 200-mile backpacking trip with my 16-year-old son and my wife and our 2 dogs. And my doctor said, you know, your PSA just hit 4 and it was 2 last year. What are we going to do? You need to go in for a biopsy. And of course, I felt like I was in the best health I'd ever been. I was like, oh, hell, I'm totally petrified about over-treatment. I need to get another test. So I got another test and it was 3.7. And I said, see, I don't need a biopsy. And she's like, the hell you don't. Let's do another test. And we came back with 4.5. And I was like, okay. So I went and did a biopsy, and the poor girl stuck her fingers up there and kind of uncontrollably blurted out, oh. I was like, you know, that's not what you want to hear during a DRE. And so I went down, got my biopsy, 9 out of 12 cores with cancer. The doctor said, you know, you got some 7s. And I was like, uh-oh, 7's the cutoff. And he said 7s, 8s, and a whole bunch of 9s. I'm like, oh, crap, because I knew what that meant. And at my age, at 55, they said, well, it may not seem clever, but we're going to go ahead and do the surgery because your bone scan was clear. And who knows, you might be the guy we reach the glove up over the fence and catch the ball going out for a home run and save you. And he did the radical prostatectomy the day before Thanksgiving 2016. So all that Christmas I was recovering hauling around my catheter. Went in January of 2017, got my PSA tested, and it sadly had not gone to 0. It had gone to about 1. And they said, oh, that's not good. Come back in a couple of weeks and we'll make sure that's not a mistake. I came back in a couple of weeks and it was almost 2. So I had a doubling time, they figured, of about 3 weeks after the surgery, which wasn't good. They sent me off from here in Denver to get a carbon-11 acetate PET scan in Phoenix with Dr. Almeida at Phoenix Molecular, and the guy that invented them. And he sat there and read it for us the day after the Super Bowl on 2017 in February and said, oh, look, you know, you got this residual cancer in your prostate bed. That's not, got my hair out of condition. You got this residual cancer in your prostate bed. That's not unexpected. He said, you know, of course, you got this big metastasis in your right hip bone. And we're like, what? And he said, but what I'm really concerned is how long have you had all these nodes in both lungs? And so my wife looked at me and I looked at her, and we both knew what that meant, and it wasn't good news. And so I went from kind of curative treatment to mets and bones and visceral organs in about 6 weeks. And they immediately ran in and said, okay, so you have what, you know, you technically qualify for high risk, high volume or something. And they said at the time, these things we used to do late when you're castrate resistant will start sooner. So they started on ADT immediately with Lupron, and then 6 rounds of docetaxel, which ran through the end of June 2017, which damn near killed me. I'd never been in the hospital before, except for the surgery, and I ended up in the hospital neutropenic from the docetaxel. Got through the 6 rounds of docetaxel, and that was the same day in kind of the summer of 2017. They came out and they said, well, we're changing the standard of care because of the results of this new study, like Stampede or one of them, and came back and said, you know, people like you, we're going to do the ADT, but we're also going to do abiraterone or Zytiga. And we didn't know if my insurance would pay for it since I just finished the chemo. Went ahead and sent it in, and they came back and said, do you want it FedEx or UPS? And so ever since, I've been doing the, you know, I do the 6-month loop runs plus the daily Zytiga abiraterone. And up to this date, I've been undetectable. I mean, it fell off in a hurry and went right to undetectable. And that's where it's been since. I now go in every 90 days and get my PSA tested. And I go in this Friday, so it's been almost 3 months, and I'm petrified because I got all these like swollen lymph glands under my neck that my internist was saying, oh, don't worry, but I kind of perseverate is her word for it. I've decided I've got lymphoma and mets in my lungs, or I mean mets in my lymph nodes, but probably not. And I go in Friday to find out, you know, if I get another undetectable or not. And they basically, once I held them up against the wall and said, how long do you expect I'm going to live? You know, one of the medical oncologists finally said 4 years to 6 years, and you've used 2 of them. So, but, you know, they're a little nervous about making that back end number. And so who knows? But right now it's not looking too good for a 58-year-old. And my son just went off to college at Dartmouth, and my main struggles are with the just the bizarre identity issues regarding the ADT that, you know, made me. It's funny, I was talking to a friend of mine whose brother realized he was transgendered and Michael became Michaela, right? And so this guy had spent his whole life realizing he was the wrong gender but needed a gender reassignment to be okay. I'm like the opposite. And so I've been taken off the gender binary to stay alive. And I don't like that very much. I was the right gender before, but now I'm not. And pretty much sucks, the whole identity issue around it all. And, you know, not only that, but the kind of short time frame of survival is not so great. So that's my cheers. It's my fake beer.
Cheers, cheers, cheers. It reminds me when I see you drinking like that, that when this group started originally, it wasn't exactly this group, but the guy that started was a guy called John Teisberg. And he started it out of Minneapolis, St. Paul, actually, St. Paul. And it was a bunch of guys who really had a group more like Speaking Freely. And I don't think any of them are still with us. I don't think any of them are still part of this group, and some of them are sadly no longer with us. But they would have a secret word. And they all had a drink in front of them, a can of beer or whatever it was, glass of wine. And whenever that word got mentioned, they took a slug from the from whatever it was that was in front of them. That's how it was when I first started with the Reluctant Brotherhood. So
my parents were terrible alcoholics. So I know I said in my group encounter, but people ask me if I quit drinking. I say, no, I finished. But like Richard Harris. But the other thing I didn't mention was the whole cognition issue. I'm a geophysicist, or was, and something they didn't really cover in detail, and I probably wouldn't have made a different choice. You know, would I rather be dead? No. But the Lupron, in my case, has made it almost impossible to work, because I was an inventor of algorithms of high dimensional data analysis. And my experience with the Lupron is that by driving my testosterone to zero, it's kind of tricked my brain into thinking I'm 110 years old. And as a result, I don't have any spatial temporal thinking. I'll drive over to pick up my mail at my virtual office, come home and not realize that I didn't go in and get the mail. Okay. And I'm also a private pilot with half an airplane. And it's like, the hell I'm going to go fly my airplane solo, because I can't, you know, I can't even remember what I was doing when I come downstairs, you know. So it's beyond the identity part. I guess the big part's the cognition, and obviously dying is not so great.
So I'd like to, I mean, it sounds like where are you being treated, by the way? You didn't mention that.
I have really good doctors. University of Colorado Medical Center in Denver. So I had a great surgeon. He done like 600 radical prostatectomies with the Da Vinci machine. Just tried to do something a little beyond what, you know, I think it already spread, but in a micro way.
Was that Crawford?
No, it was a guy named Paul Maroney.
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 And who's your medical oncologist?
It's a guy. I was so in such shock, right, when I came back from Phoenix, that I just took, you know, they said, here, you're assigned to Dr. Bernard. And he turned out to be this nice Canadian guy that didn't have any patients because he was new. But he's really good. He was from Sloan Kettering, and now he's at UCH. And, you know, I mean, I've done enough research as a scientist to know that they're doing the right things. I just am frustrated by their goal to put me in the dying class, not giving me a use by date, you know, and they won't commit to a time, of course. So it's like, well, what, we're all gonna die, so what good is it to tell me I'm dying if you don't tell me when? But
so I mean, it doesn't seem like we need much follow-up on the treatment, thank God, for the time being. If you're doing medically, you're tolerating the Zytiga and the docetaxel. It seems like where the issues lie for you are handling some of the side effects, the
identity part and the cognition part.
Right. And some of the other issues that accompany an advanced diagnosis. And we got a bunch of guys on this call who have dealt with or are dealing with some of those issues. So I'm going to throw it open right now to anybody who would like to say something to you, or who has any suggestions as how you might want to handle that, the brain fog and anything else. Who'd like to step in and speak to Joe?
Hey, Rick.
Hey, Joe, this is Len. And first thing I'd like to tell you is that at least a couple of us are getting a lot of distortion on your voice. And Rick, are you hearing that also?
Yes, I am.
I'm
So
sorry.
maybe
I may just
maybe
be
you can
too
lower
loud.
your volume.
Yeah. Okay.
I don't know, maybe that'll help.
Yeah, I'll try.
Well, the other thing is you're certainly not alone in the cognitive deficit that you're experiencing from ADT. To tell you the truth, I was on Zytiga for a while, and that was one of the reasons why I stopped. I'm not recommending that you stop. As a matter of fact, I'd advise against it, but you know, it's an issue, definite issue. And fortunately for me, I was already retired, so I didn't have to worry about functioning on the job. But if I was still employed, yes, it would have been a problem.
Yeah.
And I know there are several guys who felt that they just couldn't do their job anymore because of ADT.
Yeah. And oddly, you know, my understanding, right, is that the regular Lupron turns off the message between my testicles and my brain, and it takes away 90%. And that's bad. But we kind of did all of them at once, but I'm still kind of convinced that taking away that last 10% with the Zytiga was the nail in the coffin for my cognition. And so it's like I could get along okay with 10%. I was not as foggy or not as, you know, forgetful or whatever you want to call it. But driving away that last 10%,
10%.
while beautiful in the sense of maybe 16 more months of life.
So we can test that, Joe. There's a way to test that. The way that Zytiga works is that it attacks the testosterone, and it also stops other proteins in your body from turning into testosterone.
Right, the adrenal gland outputs, right?
Not just the adrenal gland. I mean, cholesterol can be broken down into testosterone, and so it's addressing that. Now, enzalutamide works in a completely different way. It protects your androgen receptors. It blocks your androgen receptors.
It prevents you from taking it up.
Right. So if you feel that that's what's happening, one possibility, even though you haven't failed Zytiga, is to switch to enzalutamide and see how you do on enzalutamide.
That's
and
a
see
neat
if it
idea.
makes a difference for you.
Yeah, that's cool.
You know, and that's something to talk with Bernard about.
Right.
Something to discuss with Bernard. But I just want to come back to somebody wanted to jump in at the same time as Len. Who was that?
That was me and Rick. We're on the same path here. This is Al. And, you know, I kind of I wanted to talk with Joe about this the other night, but I wanted to wait until the technical group to do it. Hi, Joe.
Howdy.
So the conventional wisdom with either enzalutamide or absolutamide, you know, in my case, I'm taking Erlita, is that you should continue to take, you know, Lupron, or I was taking Firmagon or some other androgen deprivation therapy with it.
Right.
And I wondered why that was. And I thought, I'm going to give myself a chance to see whether or not I needed to take them both at the same time. I took their Erlita as a monotherapy, and it's doing incredibly well, and it's given me a lot of testosterone to work with because of the mechanisms that you just discussed.
Yeah.
So what I was going to suggest to you was pretty much like what Rick had said. But I would try discontinuing. I would try not only substituting the Erlita for Zytiga, but I would do a little experiment
I'm on the phone.
and drop the Lupron as well. See whether the Erlita as a monotherapy would give you some respite from chemical castration.
Right.
And you could find out real quick. I mean, I'm not a medical doctor, so none of this is based on
I get it.
on medicine. It's just based on my experiences.
Well, I mean,
But
if you heard me on Thursday, you know I have this opinion that those of us who've been separated out and put in this group have more authority to talk about what it's like than those who haven't. Okay, so I get that. Yeah.
And it's a scientific experiment. So the hypothesis is that a monotherapy with a new medication will do as well as the two medications together.
Right.
And the way you'll test that hypothesis is by saying, okay, so right now your PSA is undetectable. And you're using an assay that reads out at 0.05, or are you using one of the
0.01. It's a super good one.
So it's reading down to 0.003?
0.001. I'm sorry, 0.01.
Okay, 0.01. That's good. Mine goes to 0.05, but that's good. So you have a real good early detection signal.
Yeah.
So the hypothesis is you'll be able to sustain that kind of remission with only the one medication. And you'll know right away when it breaks through, and then you'll say, well, okay, that didn't work. But now you can look at your doubling time to see, well, how fast is it going up? Because that's a very low threshold. It might hit 0.01, and it might just stay there for a while, and then you can live with that. That's kind of like what I'm doing. I cut my Erlita in half last month, and my PSA just stayed at about the detection limit. It's 0.06 now. It has been 0.05.
You're saying a word like Erlita?
Erlita.
And that's the same as enzalutamide, or?
No.
It's absolutamide. It's in the same category.
Absolutamide, okay. Yeah.
Yeah. There's a molecular difference, but they're very close together.
Right. They're doing that same blocking thing. Yeah.
Yeah, the same kind of blocking thing. Exactly.
Okay.
And,
there's the dog, by the way, if anybody's got their camera. We were all talking about dogs. Where'd you go, Stella? There's Stella.
So the nice thing about this is that, it may give you some respite from the cognitive fog. Because I've been writing this paper, and I can do some real high level, I mean, I'm old, so I can't do it for very long. But I don't have any problem, really focusing my attention quite, in a Zen-like fashion on the topic at hand. I just can't do it for very long. I have to break it up, but that's age. But, so give yourself a chance to get lucky with that. Go to your doctor. I'll send you a copy of the paper that documents mine. Go ahead.
I hear you, and that's a great idea, and I love it, honestly. That's kind of practical.
Let me jump in here. Because we have about another 5 minutes, and I just want to make sure that other people have the chance. I put the apalutamide Erlita in your chat window, so you'll see how it's spelled. Anybody else like to make any suggestions to Joe about any of these issues? The gender identity issue was a great one, or the brain fog. Anyone else have anything they'd like to add?
Joe, have you done any genetic testing yet? I mean, I hear that you're close to your son. You want to make sure that you aren't passing this on later on. Have you done a genetic test yet?
I haven't yet, but I'm going to see a genetic counselor soon. So, and we have all the samples and stuff, and I actually signed up for some advanced prostate cancer thing through Sloan Kettering, where they love my saliva and my awesome Gleason numbers so much they needed a blood sample. So I'm working on it.
And
Yeah, I think it's a smart move.
the other thing on that score, Peter, I'll come back to you. I just want to mention the Metastatic Prostate Cancer Project, if you're familiar with that, which is Dana-Farber, which is Ellie Van Allen.
I'm sorry, I meant Dana-Farber. That's the one I'm in, is the
Okay.
metastatic prostate.
So if you want to learn more about that, go to our website and listen to the presentation that Ellie made to us. It's a very, very good presentation. But what Peter's talking about is is specific to you. Peter, do you want to continue?
Yes, there are two genetic tests that are important. One is testing your tumor tissue from your RP, and that is looking for somatic mutations that might be useful in your treatment protocol.
Right.
The other is the saliva test, which is a germline test.
Right.
To see, I don't know what your family history is, but to let you know whether there's any genetic mutation that you might be passing on to your son or daughter,
Right.
or whatever,
Right.
which is probably an important thing to know, particularly because of your young age.
Right. I'm with you.
Okay. Last call. Anyone else to say anything?
This is Dennis. Don't forget the exercise. You seem to be physically active. Keep that going. That helps this stuff work better. It also helps your brain too.
Yeah, my son is this crazy mountaineer, and we actually went and climbed Mount Aconcagua in Argentina this last December, and it's 22,841 feet. So I try, but then the depression is my third thing we'll talk about on a different call. So
Okay, yeah, we can definitely spend some time on that on another call. Somebody else wanted to get in there. Who was that?
Joe, this is Jeff Dreyer.
Hi, Jeff.
I don't know if I have a suggestion for you, but I can reiterate, I can back up your experiences with mental fog and cognition problems, and as well as the fluid gender identity sensation feelings. I'm on enzalutamide and Lupron, and I had to take a medical leave because I'm a software engineer and I just couldn't really do my job well enough. So I'm not sure what's going to happen, if that will recover. I hope it is. I'm nearing the end of the enzalutamide and the whole thing. I hope it recovers. The gender part is rather interesting. I'm not going to go cross-dressing right now, but I feel a sort of a more empathy in those directions. It's kind of hard to describe. So.
yeah.
You're in touch
Okay.
with your feminine side.
Yeah.
I mean, the only 10 seconds I would add is, well, I think it was Al who had this great suggestion of going with the blocker to see if I could have more testosterone circulating but still be blocked with a monotherapy. My son's 18 and just started Dartmouth. My wife is beautiful and going to live to be 110. And since I haven't had any recurrence, right? The minute they put me on all this crap, I go to undetectable. So experimenting before I see a recurrence is something I hadn't considered, because it seems hard to justify, even though, given all these crappy side effects, it's still working, right? I mean, I'm still undetectable.
Right.
We'll find out Friday. But until that fails, if I was single, I might not be doing any of this. And I would certainly jump on your idea of, hey, let your testosterone climb up a little bit and still block it. But anything that looks like a risk, it's hard to explain to my son and my wife.
Right. Well, we've had we've got people on this call who have gone on holidays, on drug holidays. I just was talking to a guy earlier today who's often on this call, and he's just gone up to Mayo to talk to his doc, and he has Mets that went away with chemo and then came back, and he blasted them with spot radiation, and it looks like that's been successful. And he may speak a little bit about a drug holiday. But, you know, I don't think there's anything too wrong with a drug holiday, provided you keep a really close eye on it, which means...
Yeah, like maybe monthly or something, yeah.
Yeah, test every month and just watch it. But
it's just the other thing is, I talked to a guy who is doing intermittent ADT, and my feeling is the crappy stuff that's happened to me has taken 18 months. So it's like, the kind of cancer I had, I'm afraid I'd be dead by the time I felt like a man again.
Well, you don't know. You don't know how long it's going to. You don't know how long it's going to take for your testosterone to come back. I just want to say that, you know, what we seem to think is that there is no difference for men who do intermittent if they have been on androgen deprivation therapy from the outset. But for those who are using it as a second line treatment, and you're somewhere in between, actually, for those who use it as a second line treatment, there is a disadvantage. But it's definitely worth talking with Bernard. Does Bernard consider himself to be a genitourinary medical oncologist? Did he do a fellowship or any extra training at Sloan Kettering in prostate cancer? And
yeah, I mean, he's an expert in prostate cancer medical oncology, but I don't know about the genetics part.
No, a genitourinary. No, that's just.
I'm sorry. Yeah, so, no, he is. He's really good.
So talk to him about intermittent. Anyway, Joe, look, you keep coming back. We'll give you more time. You can raise issues, but I do want to move on because I still want to talk to Keith, and we got a bunch of guys on the call.
Gotcha.
So,
thank you.
Keith, you've heard the protocol here. So you're up, and tell us a little bit about yourself.
Sure. For those who weren't on the call the other day, I'll go into a little more detail than I went in on the other call. I'm calling from up in Canada, and I happened to see you guys on the net, and I got in on the call last week, and I was invited to get on this call, and I'm looking to learn from all your experiences, and I try and help men over here in Canada, in Toronto. So I'm currently 62 years old. I was diagnosed in the summer of 2015, and I had been following my PSA for many years, and it kind of was stable for a while, and it would creep up a little bit, but it never went over 2.5 or 3. And my urologist sent me back to my GP, but then it started coming up again. So I went back to the urologist until 2015 when it had jumped to about 9. So it was suggested to me that I do a biopsy, and I found I had 3 cores out of 12 which were positive. 1 was a Gleason 7, 2 were Gleason 6s. I spoke to a couple of oncologists, one a urologist and another radiation oncologist. And of course, here, I don't know how it's in the US, but in Canada, they want the patient to make the decision as to what line of treatment you want to do. So, the radiation oncologist said that there was, very good results from brachytherapy. And of course, the surgeon said, if you take it out and it's contained, then you could be free of it for life. So eventually I went for a second opinion to one of the major cancer centers, and I decided to do a robotic radical prostatectomy. So this was done in November of 2015. At my 3-month checkup that was in January of 2016, my PSA was about 0.025. It had not gone to zero. So my urologist said, let's wait for another 3 months and then we'll see what we can do. So in 3 months, of course, my PSA jumped up by a factor of 10. So from 0.025, it went to 0.25. So he said, no, we've got to do something. So he sent me to a radiation oncologist. And I managed to get on a study before I started radiation where they were doing various scans on someone with biochemical recurrence. So I managed to get a CT scan, a PET scan, an MRI, a bone scan, and luckily most of those were clear. The PET scan showed a little suspicious area near the bladder neck. So I went through 33 sessions of radiation, and at the same time I started Lupron, because they said that if I took Lupron in combination with the radiation, I would be okay. It improves the efficacy of the radiation. So I said, okay, and I did that. And then I started to have, I mean, even after surgery, I had strange experiences. After surgery, I came home and I had I had a problem because I was getting bladder spasms and things like that because of the catheter. And um, the day after I came home, I started getting hiccups, and the hiccups were for 24 hours a day, and it just went on. I couldn't sleep. I had to, doze off in a sitting position, and I went to the emergency room. They said, well, we don't know what's causing it, but we'll give you an antipsychotic, and not because you're psychotic, but because low doses can help hiccups. Well, the antipsychotic didn't work, and I went back I was called back, and I did a stat CT scan. The CT scan didn't show them anything, but in a little segue, there was a little suspicious report on my esophagus. So I went to see a thoracic surgeon who did an endoscopy, and of course, I guess I was lucky I got the hiccups because the thoracic surgeon found a gist in the wall of my stomach. So it's a small stromal tumor that's just beneath the surface of the stomach wall. So that's a separate issue that I'm dealing with. I go every year now. Luckily, that's not changed in size. So coming back to the hiccups, so then the hiccups mysteriously vanished when I got my staples removed, and so that kind of was a big relief. I started radiation, and this is something I was going to mention to Joe, that from the time I was diagnosed, I started mindfulness meditation. I used to meditate for about half an hour a day, and I still do that. I also worked out off and on from time to time, so I just got a little more regular with the exercise. So I alternated on different days between cardio and resistance exercises. So I was lucky that I got full continence back within a month or two after surgery. After surgery, I was continent, but I had stress incontinence, which I continued. I had started doing Kegels also from the time I was diagnosed, anticipating some treatment or the other. So that got out of the way, and I started radiation. I was lucky I didn't have much of an issue with radiation, but towards the third week of radiation, I started getting a lot of pain when I was passing urine. And I was also noticing small little particles of tissue that I was passing in my urine. So I mentioned this to the urologist, and he gave me Flomax. So I questioned that. I said, I don't know what Flomax is going to do. I'm getting a lot of pain, and he said, no, it'll improve the flow. It didn't. They doubled the dose, and it still didn't improve. So I finished my radiation treatment, and I had a meeting with my urologist coming up anyways. So I went to him and he said, no, he says that's not the, it's not a side effect of the radiation. I'll have to do a cystoscopy. So he did a cystoscopy, and then he found that one of the clips that they used to cut off the blood vessels during surgery had migrated and it had pierced into my anastomosis between the urethra and the bladder. So he struggled and he couldn't take it out. So I had to go back again, and they had to put me under general anesthesia and then do that. So they took that out, and luckily I haven't had any other clips floating around since then. And I finished 2 years of Lupron in March of last year. And so far my PSAs are less than, I mean, the lab says less than 0.008. So you know, so everything's for the time being is stable. So I'm not working anymore because I was, of course, I was laid off while I was under treatment. And so I decided to you know, since I was already 62, I decided to just, you know, spend my time volunteering. So I volunteer with a peer support group in Toronto. And I also visit another hospital at the prostate cancer clinic. And I talk to men when they come back after a biopsy, positive biopsy, just before they meet the doctors or after they meet the doctors. And I'm also part of a project at the Downtown Cancer Center, and I'm a peer navigator. So there I provide one-on-one mentorship for prostate cancer patients. And so that's why I said I'll learn from all your experiences. It'll help me to help the men that I meet over here, you know. So that's my story in a nutshell. And I still try to meditate every day. I try and watch my diet, and I read a lot about diet and cancer, and I exercise. So, you know, now the incentive is not to take a day off while exercising unless it's absolutely needed or there's an injury.
Very, very good. Webinars that we have available on our website, helpful both for you and the people you navigate. We have a very good website that was provided by the dietitian from UCSF Cancer Center. It's really good. We have a good one on exercise that was provided by cancer, an oncological nurse and physical trainer at Memorial Sloan Kettering. We don't have anything on meditation. We need to do that. But I agree with everything that you're saying, and we're all delighted. What you didn't mention today that you mentioned the other day is that you had extracapular extension when they came back. What was your final post-surgery pathology? What was the final Gleason score they gave you?
It was the same as the biopsy. It was a 3+4.
3+4. Okay.
Yeah.
So,
and the pathology report just said extracapsular invasion. So involvement.
Right. Do you have anything you'd like to ask this group?
No, I'm just fascinated by the experiences, and you know, I commiserate with all of you, especially, you know, if you're having a lot of trouble dealing with side effects, you know, of the treatment. And the unfortunate part is none of this can be predicted because I guess all of us, each one of us reacts differently to the treatment and differently to the situation, and you know, so it's very educative to listen to all of you.
Okay, well, a couple of things. One is we have this call, which is every week on either Monday or Tuesday, depending on the week. And then we have another call that Peter and Ken Mason moderate, which is for men with low and intermediate risk, which are oftentimes the men that you, I'm sure, are talking to. So you may get a lot out of listening to Peter's call too, and you're very welcome to do that. If you
Okay.
if you send me either on the chat window or by email your email address and your last name, we'll be sure to get you onto that list, onto my list and to Peter's list, and then you can come in and out whenever you like. Is there anybody who would like to say anything to Keith on the call?
It's great that it's great for what you're doing. I mean, a number of us are similar to that. You know, I work closely with guys, my own backyard and all over the place, you know, helping. Because the states are no different than Canada. You've got to make your own treatment decisions. Unless the doctor is so pushy and the person's so just willing to go along with it, that the doctor makes the decision. But generally, it's up to us to make our decisions, and that's one of the tricky parts of prostate cancer, is that we get caught in the decision tree, which can get pretty complex.
Yes, and that adds to the anxiety.
What I will say about Canada is that for people with more advanced disease, Canadian treatment poses a lot of problems. You know, there's a shortage of men, of genitourinary medical oncologists. Getting the right treatment is a lot more difficult. So, so for people who are being treated in Canada, and we've had several of them, we're working with a couple. It just is not easy, and our heart goes out to them when they need more complex treatment. So.
Yeah, and the other issue with Canadian healthcare, even though we like what we have, every province has different. It's a provincial service, so every province has different policies, and some of the drugs that that you all have available in the U.S. are still, some are not approved in some provinces.
Quite right. Yeah, we're aware of that. Okay. I think.
So I just did you get my email address?
I did.
Okay, good.
And we'll make sure that you are in the system going forward, and Joe is in the system, and hopefully everybody else is taken care of. So what I'm going to do now is I'm going to go down the list and see who would like some time today to talk about their own situation, and we'll go from there. And a couple of additional welcome to Bill Franklin and welcome to Larry Fish. I think I have everybody on my list. If I don't, anybody at the end can tell me that I missed them. So Jake, anything for you tonight? No. Okay. Len, anything you?
No, thanks, Rick.
Okay. Mr. Jackson, anything you'd like to talk about tonight?
Negative, still in a holding pattern.
Okay. Well, you could have other things you want to talk about as well. That's okay. Carl Foreman, anything for you tonight?
Yes, please.
Okay. Daniel, anything for you tonight?
Yes, got a significant occurrence this week that I'd like to talk about.
Okay. Jeff Dreyer, anything for you tonight?
I think I'm good. Hopefully. All right.
Okay. Dennis, anything for you?
Nothing, Rick, but I'll look forward to see you Saturday.
Oh, yeah, I'll try and be there. I can't wait to see that shirt.
Okay.
Ken Anderson, anything you'd like to to review tonight?
No, I'm good, thanks.
Good. John Appler, I think, left, unless he's back. Are you back with us, John? No, I think John left. Paul Lingane, anything we can review for you tonight?
No, thanks. For some reason, my audio connection is really poor today, but I'm all set. Thank you very much, Rick.
Okay, listen, if that's the case, are you with us? You're with us online, aren't you? Are you with us online? You can always.
Yes. Is there another way?
Well, you can always pull a Dennis Correa, and you can join online, and you can call in. Yes, you can call in.
Okay. Good tip. Thanks.
Okay. The call-in number, I don't have them right now. Somebody will post them in the window for you. But they're also on the email along with the code. So if you're having trouble, then you just feel free. Gents, could one of you just put the telephone number in the box? Thank you, Joe. And the code, which is 222-983-573. 583-973. Yeah. Thank you, Joe. There's an extra 2 on the first. There's an extra. It's 222. Anyway, we got it. Don't worry, we got it. Mr. Jackson covered you. So you got it in the window now, Paul. So if your audio's tough, then come in. Peter, anything that you'd like to talk about?
No, I think I'm okay right now.
Are you sure?
Sure.
I never know with you because we miss you, we jip you, and then you don't want to take other people's time. So you should feel free to take some time for yourself if you need it.
I'm pretty good. I had a good conversation with Jeff Turner the other day. I'm feeling good about things.
Well, why don't you tell us about the conversation with Jeff Turner? We'd like to know.
I don't know. Let's put it at the end if we need to.
Okay. Gary Gunville, anything you'd like to talk about?
I'm good, thanks, Rick.
Okay. Sylvester, anything you'd like to talk about?
No, thank you very much.
Okay. Bill Franklin, anything for you, sir?
No, I'm good, Rick. I didn't think I was gonna make it tonight, but I got back earlier than I thought.
Well, you're very welcome. And Larry Fish, anything for you?
No, thank you, Rick. I'm just listening tonight so far.
Okay, well, it looks like we're going to have plenty of time. So, Peter, I am putting you in. You're not getting up so easy tonight.
Didn't he get cheated last week?
We
ran out of time the last time, I think.
That was 2 weeks ago, and I think we spoke to him last week. But, we always like to talk to Peter, so that's okay.
I want to know where he is that it's still daylight.
Oh, take a guess.
Hawaii.
Yeah.
You're right.
You got it. Maui specifically.
Cool. Aloha.
Aloha.
We've been talking about convening a meeting in a support group meeting in Maui, and sharing in some of Peter's bananas.
I might even get out for that.
Oh, did you hear that, Peter?
You might even what?
Get out of the house for that one in Hawaii.
Oh yeah, do it.
Go ahead, Peter. Call his bluff.
Yeah, right.
Okay. That's probably you, Paul, that just came in on the telephone.
Yes, it is. I'm just trying to get all my systems running here.
Thanks. Perfect. Okay. Number 5 is Paul. Jake. Okay, so let's start with Carl. Carl, you're up.
Okay, boy, I wish I had a lot more to discuss. I've taken, in the past, I've taken up a substantial amount of time. I greatly appreciate that and this forum overall, and will continue to participate as much as possible. And I'm always a little bit freaked out when I see Peter on the video and I see the sun shining in the background, where here I am in New Jersey, where it's currently the temperature is 11 degrees with a wind chill of 3 below. So that's what I'm dealing with. But one thing I just wanted to talk about is that in some recent posts on an online forum, there was some discussion about a prescription medication called Indomethacin, Indomethacin, and it's apparently an anti-inflammatory, which is part of a clinical trial relating to killing off cancer cells, as an additional therapy for I think it says enzalutamide and or Zytiga. So I'm on Zytiga, and we kind of talked about last time that I may need to switch to another medication. Right now, the Zytiga and prednisone, the prednisone has been replaced by another medication for the past week, dexamethasone, I think is the way it's called. And I hope that will help reinvigorate the Zytiga, which I've been on for the past 6 months and have had some really beneficial impact on my PSA until recently, which kind of coincided with the robotic surgery that I had coming up to 2 months now. And well, the doctors say they don't think it's relating to me having had my prostate removed after having had several months of ADT, but we may never have an answer for that. So I just throw out there Indomethacin, whether I'm pronouncing it correctly or not, if anybody has had any experience with it, heard about it, or seen any research about it.
What is it supposed to, what's its purpose? Anti-inflammatory, did you say?
Yes, it is a prescription medication that doctors can prescribe. It's nothing to do with oncologists specifically, but apparently there have been a number of studies about how it's had tremendous beneficial impact on killing cancer cells.
Oh.
Well,
yeah, I was just looking it up here, and it's also an NSAID, right?
Yes.
Non-steroidal anti-inflammatory use for things like arthritis.
Right, and of course, arthritis, inflammation, prostate, they kind of go hand in hand.
Yeah.
So
yeah, I had brought this to Jake's attention a few weeks ago. Remember, Rick? But he wasn't interested.
Yeah, I think vaguely. Tell us what you discovered, Len. Len is our resident pharmacologist, qualified research pharmacologist. So we go to Len with all these questions.
Okay, well, Carl covered it. It was a clinical trial, I believe it was phase 2, where they have found that if you start failing enzalutamide, that if they add the indomethacin, it may resensitize, but I don't recall the mechanism.
Huh.
It's very early clinical trial.
Well, I just want to, and I don't know if this has anything to do, but I was just, whilst I was at the gym on the exercise bike, I was reading an article from the University of Chicago magazine, which I got in my PO box yesterday. It's a good article. It's on immunotherapy, and it's fairly easy to read. I mean, I can understand it, so it must be fairly easy to read. But there was something in there. That's why I just stepped off to get it. And I'm just going to read it to you, or maybe the boffins can maybe interpret this. And I don't know if it has anything to do with what we're talking about, but it says that one of the one of the professors they referred to was doing work to determine that immune boosting compounds that block an enzyme called indoleamine. And I wonder if indoleamine has anything to do with this indomethacin. It's indoleamine 2,3-dioxygenase, IDO. And it's supposed to work in combination with checkpoint inhibitors. But the test they did with it failed. And it was a fairly significant, it was a lot of money was spent and it failed. So I don't know if this indomethacin works on indoleamine.
It's completely unrelated. Completely unrelated, Rick. Different compound.
Okay. All right. Sorry about that red herring. Oh, you know what? Somebody just sent me a message. I forgot to visit with Al Fat. Al, did you want some time tonight?
Oh, was that you asking me?
Yes. I forgot to ask you.
Okay.
I'm so sorry. Did you need time later tonight?
Let me wait until the end and see what time is left at the end, okay?
Okay. All right. We'll come back to you. So anyway, Carl, thank you for raising that. And, you know, I guess we should keep our eye on it. It sounds like it's a useful compound to extend the life of enzalutamide. I did want to mention something to you. I had a very interesting discussion earlier on today with Professor Bill, who I think you've been talking to too. He mentioned he spoke to you.
Yes.
And fortunately, the good news is he feels much better. You know, he just went through his 4th chemo, and that's a tough one. It always is. The guys that are on a six cycle, it always seems that the 4th is the one that gets you. But he's feeling much better. And the question I asked him was whether we know which is the best PARP inhibitor for prostate cancer. So for those of you...
yes, a very important question for me, absolutely.
Right. And for those of you who don't know, it turns out that Carl is BRCA positive, germline BRCA positive, and germline means inherited. So all of his cells have this BRCA mutation. And so sometime in the near future, Carl could well be looking at taking a PARP inhibitor. And there are now, at least that I'm aware of, 4 PARP inhibitors, olaparib, rucaparib, talazoparib, and niraparib. Those are all the generic names. I won't confuse you with the commercial names. And there's probably nobody, there are a few people better, I'm sure there are people better, but there are a few people better than to ask the question, which is the best one in probably the whole of the country than Bill, since he's researched these stuff in his career, and he's also BRCA positive, and he's also taken olaparib. The answer is he doesn't know. He's not sure even where to look, but what he told me he would do is he's going to send an email to Johann de Bono, who is kind of the father of all of this research and was the first guy ever to suggest the use of olaparib in a prostate cancer setting and authored that study. I forget the name of the study. What was the name of that study, Carl? You'll remember.
You're talking about the Triton 3 clinical trial?
The one that was out of England.
Oh, no.
Oh, well, I can't remember, but it was one of the major studies. And so when we get the answer from Johann de Bono, we will share it with you, of course, right away. But both Bill and I think that that's a question you should be posing to Dr. Domchuk. So, you know, email her, or probably that's the best way to do it. Email her and see if you can pin her down on which she thinks would be the best PARP inhibitor for you to go on.
Right, and I guess for the benefit of those who don't know who that is, Dr. Susan Domchuk is one of the top researchers in the country, if not the world, of BRCA2 positive, I guess more so breast cancer, but also for men who have the BRCA2 positive gene. I have met with her at the University of Pennsylvania a few weeks ago, and she definitely recommended once I become castrate resistant that the next step would be for the PARP inhibitors, although she didn't specify which one. I had a brief discussion with my oncologist about it, olaparib versus rucaparib specifically, and quite interesting that the third or fourth one you mentioned, Rick, there is a clinical trial going on, and the Rutgers Cancer Institute is one of the participants. So I sent that on to my oncologist. I haven't gotten a response back from him yet. So right in my backyard, there's a study going on relating to the effectiveness of that particular PARP inhibitor. But the only thing that my oncologist mentioned, the rucaparib, I probably would not be able to get. I mean, they're all in clinical trials, so none of them have yet been FDA approved. They're expecting maybe sometime in next year, 2020 or 21, we'll start seeing the approvals. A lot of them are on fast track with the FDA, but still won't happen until at least sometime next year. So the rucaparib, he said to me, well, I probably wouldn't qualify even on a compassionate basis because you have to have had and failed chemotherapy, which I have not had. So by default, it seems
that may
at
be
this
an
point,
issue.
yeah.
So a couple of things there. I mean, first of all, as I've mentioned to you before, we have very good relationships with Clovis Oncology. Tom Harding is on our advisory board, and he's the senior vice president in charge of research there. So, and we've helped them out in the past. And so we do have access to rucaparib. Talazoparib is a Pfizer drug. And I have good relationships to Pfizer, and we help them out design the study that is probably the study you're talking about.
Yes.
In New Jersey, we looked at it, 3 or 4, myself and Joel Nowak and another guy. We looked at it and gave them some suggestions as to how to run that trial. And
it is only a phase 1 trial at this point, and it's spelled TALAZOPARIB.
Yeah, talazoparib, and that's the drug. The commercial name is Talaza, I think, or something. It doesn't matter. Anyway, the last one, niraparib, I just discovered this week, is a drug made by Tesoro, but Tesoro has a distribution and marketing agreement with Johnson & Johnson. And as you know, I have very good relationships with them too. And in fact, it was their director of, their manager of patient advocacy for their oncology division who mentioned niraparib to me. So, you know, we've got ways to ask for that drug. Now, what Bill said is that probably all 3 of those drugs are better than olaparib. And none of these drugs, including olaparib, have been approved for use in prostate cancer. So they're all being recommended off-label. But our experience has been, and I'm sure that Dr. Domchuk would agree, that most insurance companies will approve one of these drugs for men who are BRCA positive. So it's not hard to get them to approve it. The question is, what will they approve? So some of these drugs have FDA approval. Like I know that the Rubraca has FDA approval for ovarian, and I'm not sure. And I think the Niraparib has approval for ovarian. I'm not sure about the Talazoparib if that has an approval yet or not. So, you know, if the doctor's saying to you, well, I don't think we can get it, I don't agree. I mean, why could we could get olaparib for you. We could get olaparib for you for sure.
Yes, he has said that.
So, you know, why can't we get the other ones if they have approval? Now, if the approval is post chemo, then maybe there is an issue. And that might be what's going on. And I don't know enough about these PARP inhibitors and their FDA approval to know if you just have to be BRCA positive, if you have to be BRCA positive and have done certain other drugs first in order to qualify. But I think that, you know, the question is, which is the best one? That's the first question. Then we'll worry about how we get it for you.
Right, and I hope that, as I have mentioned before, Foundation Medicine, I am pending with the genetic testing from them as a result of my prostate removal and the sufficient tumor tissue that's available for their testing. So I've been in contact with them, and I did hear back from them that I've been approved for 100% coverage.
Great.
So that's wonderful news. And it should take about 2 weeks. And I am actually anxious to cover back bases with Professor Bill, as you call him, and to share with him that report. I assume I'll be getting some type of a report. And I believe it's 350 some odd genetic tests that are conducted.
Right, but you know, we already know you have a BRCA mutation, and we know it's germline, so that's going to show up, and then and whatever else. So, what I would again recommend, find out from Dom Chuck, and then we can work with you and your local guy at the New Jersey Cancer Institute, and kind of direct you to see how we can get the right drugs for you. If the decision by all of you together is that that's what you're going to do next.
Right, and I don't necessarily want to skip over Xtandi, because I think the next logical progression from Zytiga is Xtandi before going to the PARP inhibitors, but I'm not quite sure.
What's the name of it? I forget. I thought it's an Indian name, isn't it? The guy at Cancer Center.
My oncologist, Dr. Saraya.
Saraya, that's it. Yeah, Dr. Saraya. Yeah.
Yeah, and another doctor I mentioned, I think I mentioned last time, Dr. Ganesan, who's the head of their precision medicine department, you know, both Harvard and Yale trained, and I'm going to be meeting him as well.
Okay. So, all right. Anybody else want to talk about PARP inhibitors or BRCA2?
Where do you, through what mechanism did you do your genetic testing to find out your BRCA2 status?
Great question. I've had and will continue to have multiple second opinions. I do a ton of research, and one of my second opinions was with a oncologist at Columbia Presbyterian by the name of Dr. Mark Stein. Rick knows him. And Dr. Stein says, you know, I'm very impressed with your knowledge and understanding, but the one thing I haven't heard that you've had or not genetic testing. I said, well, I have tried with Foundation Medicine. He said, but what about color genomics? I said, I haven't heard of that. And he said, it's a very simple test. It's saliva. and you spit into a tube, you send it back to them, and they test for 30 different gene mutations, cancer-related gene mutations, one of which BRCA2. The other 29, I was negative, and the one for BRCA2, I was positive. And it's a relatively inexpensive test. The retail price is $249. You can go directly to them to color.com, simply that, and that's how I got it.
Well, I will say, although Carl doesn't remember, that when he told us that he had significant family, we did recommend for him to do the color test a good 3 or 4 weeks before he went to see Dr. Stein. But just saying.
Yes, it's the brain fog. It's the brain fog.
It's the brain fog. But the thing is, we record our sessions, right, Jake? So we have it. We have the proof that you heard it here first. So the difference, Joe, as we were saying before, is that the color test, which we definitely recommend if you have a family history, looks for the inherited or germline mutation, which you have a risk of passing on. The Foundation Medicine test analyzes the somatic, and you may find a germline mutation in the somatic. The problem is you don't know whether it's germline or somatic unless you've done the germline test. So Len, who just stepped away, was germline negative for BRCA, but he's somatic positive for BRCA. So he's a candidate for PARP inhibitors, but he's not going to pass this mutation on. And yes, I actually even heard that the color test is even cheaper now, but I'm not sure. So the price is going down all the time.
Great.
So,
Rick, there was, I don't know if it's still going on, but the gentleman study
yes,
was giving out, if you qualify for it, look it up on the internet, but they were actually sending people the color test for free. So.
Right. So, yes, Joe, check the gentleman study. And
I've got both foundation and color here, and I'll follow up with the other.
Yeah, the gentleman study is just a way of getting free. Didn't you have to jump through a couple of hoops there, Jake?
Not really. Just had to fill out a questionnaire to see if you qualified. You had to ask them a few questions. It didn't take long.
Okay.
And then they sent me the test and sent me the results a week or two later, several weeks later.
Yeah, what's definitely very helpful too is that when you get the results, you get a discussion or consultation with a genetic counselor. So that was very useful.
Okay, so we got.
I'll be curious whether the dexamethasone resets your Zytiga and how long it takes and how long a reset you get from it. So keep in touch with us.
Yeah, we're really expecting that to happen.
Yeah, I've heard studies on this, but I don't know how reliable it is.
Yeah. Okay.
Okay. So let's go to Daniel. And Daniel, I don't
turn it off.
I think that the week that you first came on this call, I couldn't be on the call. So I don't have any notes on you at all. I don't know if any of the other guys do. So forgive me if I'm not as efficient in following up with you.
Okay. Well, I had two rather significant developments this last week on my situation. Diagnostic PSA back in October was 43.1. Last Monday, a week ago, I had a bunch of lab work done, including my monthly PSA, and it was 4.08. So that's like a 90% reduction. So I was happy to see that. but the big news for me was my stat CT scan and bone scans at the end of November showed one lesion on the neck of my left femur. So we started ADT in December with Lupron, and then January 3rd, I started radiation to the prostate and my femur, and also started Zytiga. So last Monday was my first, liver tests, the lipid panels and all, to make sure the Zytiga isn't causing a problem, which it apparently is. There's some inflammation. But the news was that I had heard through another conversation on another forum that a gentleman similar to mine had an MRI done of his femur lesion, and it turned out it was necrosis, not cancer. So I asked my radiology oncologist about that, and I said, we didn't do an MRI. What about that? And he said, well, he just was pretty confident it wasn't necessary, but if I wanted one, he'd certainly do it. I said, yeah, I do, peace of mind kind of thing. So Monday, I also did an MRI to the pelvis in that femur area, and Wednesday got the results. And if I may, the findings were that this is most likely an enchondroma. This does not have the appearance of a prostate cancer metastasis. And I said, okay, what's an enchondroma? So I looked that up, and that is a benign lesion on the cartilage of the bone. And it was also, findings were of a low-grade lesion, but I really, it just jumped out at me. They said it does not have the appearance of prostate cancer metastases.
Wow.
Being my only, met outside of the prostate, I immediately realized that might have some significant impact here going forward. I talked to the radiology oncologist about these results the next day, Thursday, and he said, well, that's an interesting thing. He says he has seen similar films of MRIs on the femur like that, and he says it was prostate cancer, and it did kind of look like mine, so he wasn't so certain about that impression and findings. But I said, hey, unless you're telling me that radiologist is incompetent, doesn't know what he's doing, I kind of like his answer that this is maybe a benign cartilage thing. So I'm on the ADT, as I said, and I'm starting to have issues with my liver from the Zytiga. So I thought that was an amazing amount of news. I could have spent years, I guess, on treating a metastasis that may actually not exist.
Well, I hope that the most recent results are the right results, Daniel. Let me just ask you, your PSA was, were you actually diagnosed in October of last year?
Yes, October. PSA was 43.1 on a routine blood test from my primary care.
Yeah.
And we did a biopsy, and it was Gleason 7. I had 2 cores that were 4+3, and a couple of cores that were 3+4. And then they, of course, did the scans, and the scans had this, showed this lesion on my femur. And so they started right in on the idea that, ADT with the Lupron shot, 4-month, I'm on the 4-month cycle of Lupron. 1st of December, and then I waited till January 3rd to do the Zytiga because of the cost and copays. So I said,
sure,
wait till the new year so I don't have to pay 2 copays within a month of each other. So that's been the treatment plan, and my med onc has said the intention was that I would be on ADT for 2 years or so, and if my numbers stay low and down, maybe take a holiday at that point, we would see.
Mm-hmm. Where are you being treated?
I'm in an HMO, Kaiser Permanente in Portland, Oregon.
Okay.
They have an oncology department there.
Right. So that's a bit of a problem, I hate to tell you, because I have a lot of experience with Kaiser.
Uh-huh.
And I don't love the general Kaiser oncologists. What I would really like to arrange for you, and I don't know if we can do this, but you should ask your doctor, is to have your doctor consult with either one of two doctors. I'm going to give you their names slowly and I'll spell them for you.
Okay.
Either Andrea Hartstark, Harzstark, Andrea Hartstark, or Won, W-O-N, Kim, K-I-M. And both of these docs are in Kaiser Permanente in Northern California out of the Oakland urology office.
Okay.
And both of them are very experienced, excellent genitourinary medical oncologists.
Okay.
Okay. And hopefully your doc is not going to have the sort of ego that will stop him or her reaching out to them. And with both of them, you can use Ancan's name and my name, because I know both of them very well.
All right.
One Kim was my go-to guy at UCSF until he left last October to go over to Kaiser. Interestingly, with both of them, both their spouses already worked at Kaiser, and they both decided to switch over to Kaiser. And we've been trying to lean on Kaiser to have a GU Med-Onc on staff. And I suspect that Kaiser Oregon doesn't have a GU Med-Onc on staff. Otherwise, you should have been referred to him. Now, I would really value either one's opinion on whether you're metastatic or you're not metastatic, because it really makes a huge difference. I mean, the protocol for somebody like you that has 4+3 and gets radiation is 8 months, 6 to 8 months of ADT. And so that is very, very different to what you were talking about. Now, there is a way, and again, you might want to insist on this, there's a way to verify this, which is let them do a bone biopsy of the lesion.
Yeah, we talked about that. And what when we discussed that, the rest of the MRI results, which I'll just mention here, was that I have moderate to severe degenerative joint disease in that left hip. And there is a possibility of a fracture, should I be bumped there or anything, from this lesion.
Yeah.
And so I said, well, okay, a biopsy, and we had discussed a biopsy before, because I said, how sure are we that this is really, what you think it is? And he said, well, a biopsy would be certainty, but it would have to be open surgery in the OR because it's right up next to the femoral artery and some other very big blood vessels. And he said an needle aspiration is probably not doable without significant risks, which would be more than I would really want to do with it. So I said, okay. So after these results, I said, well, the way I see it is I'm going to need a hip replacement sometime in the future because I've got moderate to severe degenerative already in that particular hip. So let's just go for a hip replacement, not in the next week or two, but say in the next 12 months. Gets rid of the lesion, gets rid of the risk of a fracture from the lesion, and it fixes my hip, which is going to need it anyway. So he is going to refer, or he's going to forward my films and have a conversation with the orthopedic surgeon about my attitude or thinking on that. Apparently that's a very rare specialty. Not your standard ortho surgeons won't touch it if there's a tumor or lesion involved, but they do have one on staff that does, and he's going to try to get and he said he'll probably call me and we'll discuss it and get in a feeling from the ortho guy about that idea of let's just take care of all three issues here in one shot and see what that. So I'm kind of waiting on that. I said, well, I don't want to do a biopsy, which is open surgery, and then come back, I don't know, 5 years and do a hip replacement. You got scarring tissue, you've got the usual risks of surgery. So let's do one and knock it out. So I'm waiting for that. And
So a couple more thoughts on that, which is that Kaiser is fantastic. It's excellent for hip surgery. They've been doing it a long time. They have one of the best databases on hip surgery, and certainly in Northern California, I suspect elsewhere too, they're very, very good at doing hip surgery. I would, from my own personal experience, strongly recommend, if you're going to do it, that you do it anterior, because I had my hip replaced anterior a year ago, and Kaiser diagnosed me 3 years ago. I'm no longer with Kaiser, but had I still been with Kaiser, I would have had no qualms. Secondly, I would really ask for a consult with the interventional radiologist at Kaiser, and hear it from the horse's mouth. The lesion that you have is not biopsiable.
Probably not.
I mean, that's what your med-onc's telling you, but I kind of think that it would be a smart move if you could meet with the interventional radiologist and ask them yourself.
Okay, that's a thought. Yeah.
And you can request that.
I have another thought here. What about doing a trial gallium PSMA scan? Because a PSMA scan would probably reveal whether it's prostate or something else. And there is
a great idea.
A trial at UCSF you can get on with that one, and because that scan's more definitive than a MRI or any other kind of scan, and it specifically adheres to prostate membrane.
Correct. Yeah, that's a great idea. Or if Peter's idea is great. Len, Len, I'll come to you in a second, so you can maybe tell Daniel how he might be able to get on that onto that trial. But Axumin is another one, and I suspect that neither Axumin nor gallium are available through Kaiser Permanente.
I ended up, I should have gotten a PSMA, but I didn't know about them back when I had my scans, and I got the carbon 11 acetate at Phoenix Molecular.
Right.
It's not quite as good as PSMA, but it was $3,000. You pay them $3,000 before they do the scan.
Let me, in the interest of time, let me stop you. Almeida's great. We know him very well personally. Okay. And the way that he interprets those scans are good. But the scan itself, and he will tell you this because he's now moving to gallium, and he's got some gallium tests there too. Right. If you can get a gallium test, you're way better off. There's actually something even better than gallium, but I just don't want to confuse the issue right now. If you cannot get a gallium test, you should ask for an Axumin test. And both of those, you'd have to fight at Kaiser, but you might have a shot at having them pay for it, especially the Axumin test, because you need to determine if it's, as Peter says, you need to determine if it's prostate cancer, and these technologies will do that. Well, the Axumin will not, will it, Peter? The Axumin will just show a lesion.
Right. I think you have to go with the PSMA scan.
Yeah. You're right. The Axumin's not going to tell you, but the PSMA scan will, because that's sensitive to prostate-specific membrane antigen, so it only shows up on cells that express that antigen. Len, how did you go about getting that test, that clinical trial, or where are you with it?
By the one at UCSF?
Yeah.
I actually got it through Peter, the information, but I can forward it to you, and you can forward it on to Daniel, since I don't know his email address.
Okay. Yeah, I don't. Yeah. Daniel, I don't have your email. Hold on one second.
Another one.
just hold on one second. Daniel, I don't have your email address either, so you need to send it to us if you would be kind enough to do that.
Okay, I'll send it here in a second.
Okay. And Peter or Len, go ahead.
I was just going to add that there's another trial at the NIH with F18 DCF-PYL, or just F18 pill. And that one's supposed to be even more sensitive than the gallium-68, whichever one is more convenient.
Right. That's what I said. I didn't want to confuse Daniel with that one. So
Daniel lives in Northern California. If I'm not McKinleyville or something. Right? Yeah. So I mean, get an email and we'll get you the information about who to call. Her name is Smith. I can't remember her first name. But she's
Raven Smith.
Raven Smith at UCSF, and she's very approachable. She'll call you back within a day or so, and you can explain your situation. She'll let you know if you qualify for the trial. At the most, you might have to pay $900. It's a one-day thing. You can go down and do it in one day and be back. And UCSF, has very highly qualified people to read the results and so forth. And anyway, it might be useful to explore that option. I have a friend here in Maui going in a week or so to do the trial there for that purpose.
Okay, yeah, I'll keep that on the list here too.
Okay. Yeah, I mean, I think that you've got to sort of try and do your best to tie down if this in fact is metastatic or not, because it's going to make a huge amount of difference to your treatment.
Right, and I meet with my medical oncologist next Monday, just as it was already scheduled visit, but we'll talk about this and see what he thinks about all of these ideas or these changes. I realize that, I may still have some micromets floating around in there waiting to try to find a home to set up camp on, but since that was my only visible lesion, I kind of like, wow, this is good. I'm hoping this is better news than it even sounds like.
Well,
Daniel,
go ahead, Peter.
My email is peterk@ancan.org. You can, if you respond to that, I'll send you the information.
Okay.
Yeah, and I have Daniel's email, so I'll put it in the chat window for you right now. I did have it. I didn't realize that's who you were, Daniel. I didn't have your last name, but now I do. So.
Okay, good.
So yeah, you should have gotten the advice for this meeting too.
Yes, I did.
Okay, so yeah, so Peter, I've just sent it to you. Okay, well, I think that's what's on the agenda for you is to talk about the gallium trial, to tie it down and to try and get a consult with one Kim. I would say one Kim would be the best, at least a phone consult, or have a three-way consult with yourself, the oncologist, and one Kim. And one Kim's going to be very familiar also with the gallium trial at UCSF. So keep us posted if you would.
Okay, I will do that. Sure.
Okay. Anybody else want to say anything about this pretty remarkable situation we don't hear about? I think this is a first. I don't know that I've heard this one before.
Daniel, I'd like to know what was the scan that revealed the hip lesion that you think may not be a real lesion? What type of scan was it?
Well, the initial scans that showed that there was some lesion there was a nuclear bone scan and CT scan back in late November. actually the CT scan, they didn't see it at first because they only looked down through the pelvis. But when they went back after the bone scan lit up and they looked a little lower, then they saw it on the femur. So this one was just an MRI to the pelvis with and without marker that we did last Monday. And then that showed up within the MRI. It was just a conventional MRI.
But that first scan, you said it was a nuclear scan. Was it an F-18 scan or a technetium 99M?
I don't know I don't know anything more than what they listed, which was nuclear bone scan. Just I guess their standard process that they do, and then a straight up full body CT scan. Although they only read down through the pelvis to the top of my head on that one. So I don't know the specifics of that.
Okay. All right. Let's keep moving along. Peter, do you want to give us a quick update of what happened when you spoke to Dr. Turner?
Yeah, I kind of went, I think I'm in pretty good shape. We're going to go to 6 months rather than every 3 months now for follow-up. Just as reference to Joe, I do my PSA test every month, and it's such a cheap test that you can ask your doctor for PSA, both PSA and testosterone. It's useful. That takes a lot of anxiety away. I've done all the genetic testing now, including finding out where I stood with MSI, finding out where I stood with PDL1 and so forth. So essentially what I'm doing is banking this information. None of it's needed right now because my situation is relatively stable. I'm on a holiday and just watching things. But at least I know what the options are down the road. I know that I might be a candidate for carboplatin. I know that I might be a candidate for Keytruda. I know that I might be a candidate for olaparib. I know these things are possibilities, and I know the parameters now. But I feel comfortable in that rather than waiting until the end and scrambling around doing tests to find out what you could possibly do. It just feels like I've got the information in the bank, which makes me much more at ease right now. So that's where I am. I've done the proton beam radiation for my Mets, and I know I can go back there again if more Mets show up. I can go back there. I know I can do another gallium scan if that's necessary down the road. So I've got a lot of backup plans, and I think it feels like a good place to be in for me anyway. So that's my report.
Peter,
I think Turner agrees with that too. I mean, he's comfortable with it all.
What's your last PSA before you stop the HT?
0.03. Lowest it's been.
Okay. Excellent. And when are you and you're not planning to test again for 6 months, did you say?
No, I consult again in 6 months, but I test every month.
Okay, got you. I was going to say because that wouldn't be a good idea. Test monthly.
One other thing I'll mention with monthly testing is, when you've been on drugs, Zytiga does get out of your system in 1 week apparently, but a lot of things take a time to come back. Like your so it's wise to get a comprehensive blood panel done. So keep an eye on your whites and your hemoglobin and so forth, because mine dipped down quite a bit.
Okay.
Hoping they come back. Also, blood pressure and all those things that get affected by these drugs. So it's helpful to do monthly testing.
Yeah, I was going to ask you: is your hemoglobin back up a little bit?
No, it's still down.
Still down, huh? Okay. Okay. Well, hopefully it'll come back. Anybody have any questions for Peter? Okay.
So Peter, you said Leonard doesn't need to see you for 6 months, but you're still going to have monthly PSAs. Did I get that right?
Oh yeah. If something goes south, we'll be on the phone fast. Yeah, I'll do monthly PSAs.
Okay. Well, congrats on the PSA. Good news.
Yeah, very good.
I'm going to follow your lead.
Okay. Mr. Foodie, I see you arrived. Hello, hello.
I did. Hello, how you doing?
Good. Al Fat may want some time, but did you have an update? Have you seen Dr. Rathkoff since we last spoke to you?
Yes, I went to that meeting with 4 questions, and question 1 was, if this trial that they're proposing did not exist, what would my treatment be? Just the reference point, my Xtandi was showing signs of beginning to fail as my PSA was creeping up, doubling in a year, and then doubling in 3 months, and then doubling in a month. And so the path would have been, as you thought, from Xtandi, it would have been Zytiga with prednisone, and the expectation would be that the Zytiga would not be as effective. I got 4 years out of the Xtandi, but they didn't think that the Zytiga would have any kind of a benefit like that for me, and that as the Zytiga it would work, and then it would start to lose its effectiveness, and then I'd move on to docetaxel. So I said, okay, all right, so that's that would have been the path that I would have gone on. Now we have this clinical trial. So how do you compare, like that plan, the Zytiga plan versus this trial? And the trial is a combination of Zytiga, prednisone, and cabazitaxel. And they said, well, first of all, the perceived benefit of this trial is that the Zytiga would help manage the cancer, the cabazitaxel would help destroy the cancer. So in this trial, they're looking to see if that combination can have a significant positive effect. And they said, in your case, the CT scan revealed a mass, and that was in December. I had a biopsy in December 31st, and the biopsy revealed that it's cancerous with prostate cancer. It's in a lymph area right next to the prostate gland. So this is the first. I do have bone mets in my sternum in my right hip. So this is now going from the bone met. Now I've got a met in a lymph node, one lymph node. So they said that they were concerned that this was an aggressive cancer in this mass, small mass, 3 centimeters. So that sort of changes things for me, because they felt that this trial was an opportunity to be aggressive in fighting the cancer, and apparently this cancerous mass has the potential of being an aggressive cancer. So the good news is that the CT scan from December to January showed that the mass remained essentially unchanged. So that was positive news for me. So anyhow, I said, okay, then, what happens if I do decide on the trial? What happens if it doesn't work? And they said, well, and these were all questions that came from talking to you guys. And they said that, well, if it doesn't work, there's always new medications coming down the line. And so we would evaluate your situation at that point. And I said, okay. So they said, what do you want to do? And I said, well, I want to do the clinical trial, because with that new mass, I thought it'd be best to be aggressive in my treatment. And it seemed like reasonable. Both drugs were FDA approved. I'm under great supervision. so I had my first chemo a week ago. I forget the date already, and thank goodness I did not get sick. And I've been taking the Zytiga with the prednisone. My energy level's been good. My mental functioning has been good. I've been resting. I've been trying to get 7.5 to 8 hours of sleep a night. I've been, watching my diet and not, going on potato chip binges and things like that. But I've been more active exercising, beginning to get back into that training. And, I just tried to be relaxed and calm and emotionally calm, but as well as singing every now and then to feel happy and, trying to think happy thoughts. And so I feel good. They're monitoring my blood every week. I used to look at my lab reports, but I decided I don't want to look at my lab reports because I don't know what I'm looking at now with this new, chemistry going on in my body. And so I'll have my next treatment February 1st. It's every 3 weeks. It's either 7 months or 9 months, and Zytiga every day with the prednisone. And I'll have more CT scans and bone scans about mid-March, I think it is. I feel good. I feel okay, and I feel like I believe I'm doing everything that I can to help heal my body of cancer and help stop and slow the progression of the disease. And so that's my update.
Well, we wish you lots of luck. By the way, for those of Richard mentioning his singing, this is not in the shower or in the bathtub, but Richard sings with a group. And when he first came to us, he was in the chorus, and now he sometimes takes the lead. So this is very impressive singing that he does. We wish you every success with that. It sounds like a lot of cabazitaxel. So you're talking about at least 9 sessions. Is that right?
It's either 7 or 9 sessions every 3 weeks.
7 or 9 sessions. Okay.
So it's 1 session, and then 3 weeks later, the second session, and 3 weeks later.
All right. I thought you said 7 or 9 months. So
right, over the course of 7 or 9 months. So it's every 3 weeks, one chemo session every 3 weeks over the course of 7 or 9 months.
So that's a lot of chemo. So if it was 7 months, that's 9 sessions of chemo or more. So that's a lot.
Well, as I said, they're monitoring it. They're monitoring my blood every week. With the trial is they'll pull the plug on it at any time when they feel that my body's not responding, or the possibility of liver or other sort of damage. It's not mandatory to do the whole program.
Okay.
Did you say
is this while are you on Lupron too at the same time, Richard?
Yeah, exactly.
Oh yeah, I am. I'm on Lupron as well.
Okay.
And I'll be back. They took me off of when they stopped my Xtandi. They also took me off of Zometa. But when I get my Lupron shot soon in February, I'm also going to start back up on Zometa. So I'll be having Lupron and Zometa, plus the Zytiga and the prednisone, and the chemotherapy cabazitaxel.
Wow.
Okay.
Well, the one thing with the Zometa, Richard, is that it has an awful long half-life. So, you could talk to Dana if you can take less Zometa whilst you're on there, just to ease the drug burden on yourself. It's got a hell of a long half-life, that Zometa. Okay. So, you can take a vacation on it. And, how often were you getting it? Once every 3 months?
Yeah.
Yeah. So, you may be able to miss a session. It's probably not going to make a whole heck of a lot of difference, but talk to them about it and see. But yeah, we wish you every success with that. Anybody want to talk to Richard about this protocol?
Are you still doing dragon boat practice while you're doing all this protocol?
Yeah, the training started, and it actually started the day after my first chemo treatment. I decided to just rest. I didn't want to go and begin the training. That's the physical fitness training. So on Wednesday, Wednesday, I'll be going to there's a boot camp, and that'll be my first training for the 2019 season, and I'll need to be working out like 2 to 3 times a week. So
wow, good for you. Good for you. You have a special race for Chinese New Year this year? Next month?
Sorry?
You have a special race for Chinese New Year coming up next month?
No, not for Chinese New Year's, but the team has decided, they voted to compete to qualify for the national competition in Colorado. So this would be to win the USA, the USA National Championship, and we have to be successful in, I guess, 3 races. Our first 3 races, we have to do quite well to become a potential qualifier for this national championship. So
wow. And where's the international championship this year? Last year.
Well, it's every 4 years. It's like the Olympics. It's every 4 years.
Every 4 years. Okay.
So the next one's in France.
Okay. Well, for those of you, again, just to fill in the background, this is the Memorial Sloan Kettering Cancer Center non-breast cancer dragon boat team. Is that right?
Well, it's close. It's close. Memorial Sloan Kettering does have its own dragon boat team. The Empire Dragons, New York City, we have 2 teams. We have the breast cancer team and then the all cancer survivor team. So I'm on the all cancer survivor team.
Okay.
Men and women.
Okay. Yeah. Fantastic.
Thanks.
Good luck to you.
Thank you.
Good luck to you. All right. Any other questions for Mr. Foodie before we finish up? Okay. Let me just make one quick announcement for everybody, which is just coming together and I think will happen. Next Tuesday night is the 5th Tuesday of the month, so nothing is scheduled. However, Professor Bill has kindly volunteered to give us, not just us, because I think we will advertise this widely and there could be people from other cancers attending, a Genomics 101 primer, so that we can speak more wisely and sensibly about this genomic testing. So, for example, I always get confused whether a gene is bigger than a cell or a cell is bigger than a gene. And is a molecule bigger than a cell or a cell bigger than a molecule? So this is the very pedestrian level that Professor Bill has promised to address. And there will be a slide presentation. He's done this presentation before for patients at Roswell Park. And we're very excited that he's going to do it for us. He's pretty certain he's going to feel good because he doesn't have another chemo till the 31st. And if we have to cancel it, we'll cancel it. But we don't think that's going to be the case. And we'll probably start pushing it out tomorrow on the internet and elsewhere. And hopefully we'll have a really big crowd for him because there's a lot of interest in what this genomic sequencing is all about. And for many of us, we have to start at the very bottom rung to understand it. Len, did you want to add anything to that?
No, I think you summed it up nicely, Rick. I'm just
Okay.
wondering if Al had something quick he could pop in with, or we need to wait.
No, I think I'm okay. It's just been an incredible session. Rick, we'll continue our email correspondence
Yes.
about whether we can actually, I'm going to see if I can attend that gala.
Okay, yeah, no, I'll write back to you. So for those of you who are in the metropolitan area, Mr. Foreman, that includes you.
Yes.
I will be at Chelsea Piers on the 7th of February. And this is a fundraiser for Prostate Cancer Foundation. I think the tickets are $150 a pop, fully deductible. All the money goes to Prostate Cancer Foundation, and sadly not to us. I wish we had a cut of this, but we don't. And let me just say that it's a very, very nostalgic invitation for me personally, because Rob Beniscus was invited last year, my co-founder, and he was too sick to go. And Jansen came to me last week and asked me if I'd wear a blue coat on their behalf. And I feel like I'm wearing it on Rob's behalf too. And then some of you may remember Dan Zenker and the blog My New York Minute. Dan was the senior vice president of communications for PCF, and I supported him. He was diagnosed with micrometastasis within about 2 months of joining PCF, which was kind of an irony. And he passed away from a heart attack, which may well have had something to do with his disease and being on ADT for several years. And so I feel like I'm wearing that jacket for him too. So we're I'm very happy to be part of it. There'll be a bunch of media stuff I've got to do as well, with radio, TV, and print, I believe. But Jansen's setting this all up. So,
Rick, is this individual tickets, or is there going to be a table around you?
Individual tickets. Individual tickets. So if for more information, it was in my, I put a link in my, I'll put the link in again. So it was in my last distribution, but if you go to PCF or if you Google PCF Blue Jacket Gala, you'll find all the information about it. And I'll be there.
Len, are you going to go?
No, I'm down in Florida, Richard. I'll be down in Florida till mid-April.
Okay.
Yeah. Otherwise, he would have been required. It would have been mandatory, but he gets a pass because he's in Florida.
Okay.
And I would have been hosting Rick for his accommodations if I was up there.
Yeah. And he would have been throwing tomatoes at me from the audience. So,
what?
So now throwing tomatoes might be left to those of you who are there, like Mr. Fat and Mr. Foreman and Mr. Foodie. Oh, look, they're all Fs. Well, they're not really all Fs, but they're close to being all Fs. Fat, Foreman, and Foodie. All right, and anybody else? All right, guys, thanks for your attendance. Our next meeting will be on the 4th. Yes, our next meeting will be on the 4th, because next Tuesday is the 5th Tuesday, and we're having the plenary. So next meeting will be the 4th of February. All right. Good night, everybody.
Good night. Thanks, Rick.
Good night.
Good night, everyone.
Hey, Rick. Thank you.